Welcome to AETCM. Today we're discussing about a 53-year-old man who came to you with complaints of breathing difficulty. So, a 53-year-old man was brought to you with complaints of progressive breathlessness past 3 days. It worsened that day around afternoon time, which brought him to the hospital. On arrival, he was actually brought in a trolley, but on my initial 10 seconds, he was gasping. He was not responding to pain, and he appeared to be in severe respiratory distress. His extremities were cold and clammy, and he was sweating profusely. But when I tried to palpate the pulse, carotid pulse was palpable feebly. Some feeble pulse was palpable, but he was in severe distress. I quickly went to the primary survey. His airway didn't appear to have any secretions or any obvious obstruction, but his maintenance was questionable because of low GCS. A breathing part, he was gasping at this point. Circulatory part, he had a pulse rate of 42 per minute, but BP was not recordable. And when we considered the monitor saturation, nothing was recordable. So only a palpable minimal pulse was there in the carotids. That's the only thing. At this point, I immediately obtained a last bore IV cannula, and at this point, we give 1 milligram of atropine. We connected the patient to monitors.
What are the reasons for hypertension with bradycardia?
One thing could be like secondary to bradycardia itself.
According to ACLS, how many H's, how many T's?
It could be like secondary to like 5 H's or 5 T's. It could be secondary to hypoxia, profound hypoxia. Then again hypovolemia due to blood loss or something. Then again hydrogen and acidosis can be there. Then acidosis can be there. Then hyperkalemia can be there. Then hypothermia. Coming to T's, it could be secondary to some toxin, or maybe secondary to tension pneumothorax, or cardiac tamponade, or coronary pulmonary thrombosis. This could be the possible reasons.
So whenever you have a patient like this, you have to look for all these causes.
So this patient was brought in like in a state of acute distress with some mild feeble pulse was present. Airway was at present patent, but maintaining was not commendable at this point. Breathing was gasping. Circulatory part, carotids, we had got a pulse of around 42 per minute and around 40. But we gave a 1 milligram atropine initially. But even after that, there was no change in the heart rate. About 44 was any change in improvement.
Initial examination, what are the findings of the neck veins and trachea?
On initial examination, actually, the neck veins appeared to be distended. Trachea was in central, but neck vein appeared to be distended. Okay. And so, after giving atropine again, there was no change in rhythm, but we reassessed the patient. This time, there was no pulse palpable. So, the patient presumed to be in cardiac arrest. So, we immediately started the patient with CPR. CPR was started with chest compressions and ambu ventilation. We gave a rate of 30:2 at a compression rate of 100 to 120 per minute. And we continued to give adrenaline. 1 milligram was given every 3 to 5 minutes, followed by 20 ml saline push was given. And also we intubated the patient early itself with an 8 size ET tube and fixed at around 21 angle of mouth and confirmed by 5-point auscultation.
EBG was taken during that before arrest.
Before arrest, we couldn't take. Immediately after ongoing arrest, we took an EBG. It was showing a pH of 6.8 with a PCO of 93.2, pOT of 10.6, then bicarb of 13.3 and lactate of 9.1. Was on arrest EBG. So CPR was ongoing. All the reassessment rhythms were persistently showing asystole. We confirmed asystole by checking the asystole protocol. We checked all the leads. We changed the gain of the defibrillator. We checked the lines. Everything was intact. So we confirmed it to be asystole. And the CPR was managed as per ACLS protocol according to this thing for ACL asystole. So we continued compressions along with adrenaline was given every 3 to 5 minutes. So after we got this ABG, we also gave the patient this soda bicarb was given, 50 milliequivalents was given, and also we tried giving a saline push of 500 ml bolus was given. So
what is the action of soda bicarb in this type of conditions? How do it act?
One thing is actually soda bicarb actually indicated in cardiac arrest mainly for hyperkalemia with metabolic acidosis, or also in case of severe metabolic acidosis as less than 6.9 pH. So even though it is like a transient phase, it can slightly bring up the bicarb for some time duration to improve
the advantage.
It can prevent a further arrhythmia or like.
Most of these drugs you give, adrenaline, noradrenaline, they work in a normal pH only. If the patient goes to acidosis, these drugs may not work at all. So to improve the quality of that drug, you have to give sometimes, like especially conditions like this, There is transiently we have to improve the pH. Okay. In acidotic media, they may not work properly. So we have to be very careful. If the patient is in severe acidosis with hypotension, whatever
Drugs
medicine
will
you
not act.
start, it may not act. So for a good cardiac activity, sometimes you'll have to give soda bicarb. It has got its own side effects that has to be taken care of.
Also, metabolic acidosis can again itself be a cause of arrhythmogenic. This thing can create arrhythmia. So again, can be helpful. So we gave 50 milligrams of soda bicarb was given and CPR was continued. By about fifth cycle, we got a rhythm in the monitor on reassessment, but there was no pulse palpable. So considering it as PEA, pulse electrical activity, we continued CPR. Again, on the sixth rhythm cycle, also we checked the this thing. We monitor was showing an organized rhythm. It was like a sinus tachycardia of about 140 heart rate. Previously present narrow complex tachycardia with 140 heart rate, but still with no rhythm. So at this point, we arranged for an echocardiogram.
At this stage, did you intubate the patient?
Intubation was earlier done, sir.
But you didn't mention.
So intubation was already done in the initial stage itself.
All is important. Patient is in respiratory distress. So immediate thinking airway. We start with the airway, then we have to go for the other thing. So as soon as the airway is assessing the airway, there is a suspected patient is consciousness altered. So maybe first thing is tongue falling back. To
Secure
prevent
the airway.
any aspiration as well as to maintain intubated.
So by about sixth cycle, the patient is persistently having pulseless electrical activity with a monitor showing sinus tachycardia, but with no palpable pulse. We
How
continued.
do you differentiate SVT from sinus tachycardia? Because heart rate is now 140.
One thing will be absence of pulse. I mean P wave. P wave will be absent, or it could be like an inverted P after the QRS could be also be present.
So normally it is absent. If it is present, sometimes it can be inverted.
So while ongoing CPR, we arranged for an echocardiogram just to quickly have a look at the heart. One thing to rule out any pneumothorax or secondary pericardial effusion or tamponade. So while looking for the echo activity, like we saw good activity in the heart, but it was around the pericardium was filled with some collection. So we put in three positions. One is in the apical position, one in the parasternal long axis view, and also in the substifoid view. All was showing RV collapse with RV and RA collapse with significant pericardial effusion, but cardiac activity was intact. So presumably this patient is having pulseless electrical activity, but the underlying reason is actually the patient's heart is surrounded by fluid, which is not allowing the heart to expand. So the heart itself has actually a contractility and activity by itself, but is not able to create adequate cardiac output because of the compression by the pericardial effusion. So considering this aspect, we stopped CPR at this point, but
Where is the problem? Relaxation or contraction?
relaxation time, the blood is not filling into the heart.
Relaxation is impaired.
So, considering this finding, we initially gave fluid boluses. We started the patient on noradrenaline support during ongoing CPR itself, and then we withheld the CPR for some time. By the time we already arranged the patient for emergency tapping for pericardial effusion.
RV is collapsed. That you have seen other conditions where RV is collapsed and reduced volume. Other conditions.
Any IVC obstruction? Any outlet obstruction? RV is collapsed.
Constrictive pericarditis and all, you get similar finding, but they are chronic. They never come to ER. Okay. Restrictive cardiomyopathy, constrictive pericarditis, they're all you get a similar type of picture. Normally, we don't see that because they never
Not an
come
acute.
to ER. So only here we are seeing it.
So this patient at this point, we started the patient inotropic support. We gave IV fluids, but it was not. We are not getting a palpable rhythm. But the monitor persistently showing the tachycardia picture, and on echo we are getting adequate cardiac activity, but with no palpable pulse. So we immediately arranged for a pericardial effusion tapping. So under safety precautions, we arranged, we cleaned the area, substifoid and sufficiental region with betadine, and about we took an 18 gauge spinal needle. It was introduced between the substifoid and the left coastal area. about 2 centimeter below the thoracic cavity, and towards the left shoulder. We directed the needle in an posteriorly upwards and laterally placed angle, and we also, with the help of USG, we already have a USG, so we place it along with the needle for echo guidance. So with the USG guidance, we introduced the needle and we were able to withdraw initially about 10 ml of darkened bloody aspirate. So once the aspirate was confirmed, we connected the needle to a 3-way connecting cannula. So we connected 10 centimeter extension along with a 3-way, and we started tapping the pericardial effusion. So we drained about 220 ml of bloody aspirate from the pericardium. And once the tapping was completed, we got a palpable pulse. And after some time, the heart rate also slowly started coming down. So by about 10-15 minutes, the heart rate come down to about 98 per minute. So after the pericardial tapping, we got a pulse rate of 90.
What are the important signs of this type of conditions, like cardiac tamponade? What are the important signs, clinical signs?
One thing, the patient may be complaining of progressive breathing difficulty with
Three important signs.
UP and this thing,
Hypertension.
hypotension.
So three important.
Next slide.
Same thing you can get in
Pneumothorax also.
pneumothorax. Okay. So that there the name is not given. That's all. Okay.
So this patient actually on initial arrival itself, on clinical examination, we noticed to have distended neck veins, but we couldn't correlate to anything at that point. So since we already had access to USG, we could easily find the pericardial effusion. So after aspirating the patient's ROSC, actually got, we can call it ROSC by now because we got a spontaneous rhythm with pulse. So the patient was then arranged to shift to cath lab for further management of for emergency remaining tapping and also for sheath placement. So currently the patient, after the patient was taken to cath lab, and under fluoroscopic guidance we continued to tap this thing. About 500 ml was totally drained from the pericardium. After that, the patient's that condition was stabilized, and currently he is on ventilator on anaerobic support, but he is maintaining his vitals and is recovering. So basically what we had was a case of a malignant pericardial effusion in a 53-year-old male who was brought in gasping, went into cardiac arrest, and lastly became into a state of PEA, pulsatile electrical activity. And after tapping, we got the rhythm back along with pulse.
Okay.
So some things to notice actually, arranging for tapping, complications that can occur. One thing is, especially if you don't have a ultrasound guidance, the technique is almost same only. The approach can either be from the subsiphistranum approach, or maybe we can use the parasternal, and other approaches are also available. But whenever we are using blindly, we go for the subsiphistranum approach. So whenever we are passing the needle, we have to watch out the monitor for any acute change in rhythm. Any arrhythmogenic or ectopics in the monitor is suggestive of the needle touching the ventricle. So whenever we are getting a rhythm like that, we have to pull back the needle. And also, instead of slowly advancing the needle, we have to move it like a small quick jab should be done, because actually some push is needed to enter the pericardium. And also, if you are actually continuing CPR also, we can continue the CPR until the area is cleaned and we are about to introduce a needle. Until then, we can continue CPR, and almost when everything is said, we can briefly stop the CPR and start the procedure. So what we do is actually, especially in adults and all, we take an 18 or 20 gauge spinal needle, and we place it at a 45-degree angle, aiming at the left shoulder between the subsiphoid and the lateral aspect of the middle aspect of the left inferior costal margin, and we aim it towards the left shoulder. And we introduce it in a small jabbing technique, so that it enters the pericardium. And once we start getting aspirate, we hold the needle at that position. We connect a 10 centimeter extension along with a 3-way connecting stopcock, and then we start draining the fluid. And we watch out for any turn of pulse or any improvement in BP. So this can be done, and if you are not getting any pulse, we can again withdraw the needle and slowly bring it up so that it goes at a slightly above the 45-degree angle, but aim the needle more posteriorly, that we can try. So this is the basic.
Normally fluid will come out unless with tuberculosis and all, you can get encysted effusions. In that conditions, you'll have to call a surgeon for your help. Otherwise, normally fluid will come out because it's a tense sac. Immediately, if you puncture it, it will come out.
So complications that can happen is, one is cardiac arrhythmia if you're touching the needle with the ventricle. Second is pneumothorax can happen. Third is accidental puncture to the heart vessels like coronary arteries or anything can get punctured. And the fourth will be any injury to associated structures like stomach, liver, or diaphragm can happen. And also, immediately after the procedure, we have to monitor the patient for continuous hemodynamics should be monitored. And also, if the patient was ongoing CPR, we should immediately start CPR once the drain has been completed. And also, once the ROSC has been attained, we have to get a proper echo of the heart. And also, we have to document the pericardial fluid. That is the amount of fluid that has been drained. Also, send the sample for further evaluation, like cytology and also protein, sugars, everything has to be evaluated. This is also if the pericardial synthesis is unsuccessful, if we can have facilities available.
So, how do you know that it is traumatic or hemorrhagic? This fluid is bloody fluid.
This thing traumatic
Because
will be
traumatic
like
means when you are tapping, it can produce injury and it can bleed. Hemorrhagic means it is infiltrated as blood. Itself into the pericardial sac. That is commonly occurring in malignancy, tuberculosis, and tuberculosis. Initially it will be hemorrhagic, then it will become pus. Both are possible. Malignancy, it is mostly hemorrhagic.
So it's more
hemorrhagic and traumatic. It is you keep the sample for some time. If it is a traumatic, it will settle down. Whereas in
the color will be like homogeneous.
Other one, malignancy, it will be same. It will not settle down. That is easily you can make out. Then you can send to the lab also.
So one more thing to notice in this patient, actually we stopped the CPR in between to do the procedure. So there has been some newer studies regarding the pulseless electrical activity. So as per ACLS, whenever getting a pulseless electrical activity, it indicates that there is absence of pulse with no cardiac activity, but we are getting some electrical activity in the monitor. But if you think about the actual cause of this kind of a situation,
normally what is the treatment for pulseless electrical activity?
We continue CPR.
Continuous CPR. That is the most important.
But if we look at the physiology of this event in a deeper perspective, this pulseless electrical activity can be a spectrum of issues which can be like an actual non-moving heart. We call it pulseless electrical activity with echocardiographic standstill, or PRES. And on the other spectrum, it could be a pulseless activity may be there and electrical activity may be there, but it is not creating adequate cardiac output due to profound hypotension. So in those kind of conditions, if we are able to actually visualize the heart's activity by an echo, we can try correcting the hypotension by other means like inotropic support, fluid, and all that.
Here, which one will work well, fluid or inotropic support?
In this patient, the only thing will work is the draining of the
that is correct. Draining of the thing is number one.
Second is fluid.
Before that, fluid. Not inotropic support. Here we have to fill the RV. Then only you can get a good output. Okay, then it is very difficult. Theoretically, you can tell, but practically you have to remove the fluid.
So as per the newer studies, if you are getting a pulse electrical activity, if we have access to an echocardiogram, we can quickly check the heart's activity. If the heart is showing adequate activity, but there is no palpable pulse, we can think about it as a state of a pseudo PA, or maybe the patient is in profound hypertension. So either we can have a choice of either continuing the CPR, or we can hold it for some time, but same time we can start the patient on either IV fluids, inotropic support, and also get either a bit more advanced monitoring device like an RTLN or something, so that we can get the adequate correct BP recording of the patient. So monitoring using this RTLN, we can monitor the hemodynamics of the patient, and we can give other corrective measures to correct the PA. So in a lot of conditions, the PA has reverted just by this means, even after stopping CPR. So PA doesn't always.
PA with the cardiac tamponade, it is not a must that you have to continue
CPR.
Here, stop CPR and remove the fluid is better than
continuing CPR. So that's what we did in this patient.
What are the ECG changes you get in tamponade?
One thing is it could
Normally, you don't get time to do that because most of the time patient will be
unstable.
unstable. So, but what are the ECG changes usually you?
One thing will be low voltage. This rhythm will be there, and also rarely we could get pulses alternance. It could be there.
Pulses.
Electrical alternance.
Both are different. Pulses alternance is on.
You feel
Examining the pulse, you are getting alternating high and low volume pulse. That you get in
this thing.
cardiac failure. This is electrical alternance. This is high voltage complex, low voltage complex. What happens to the heart? Why we are getting like that? Heart swims in that water. So one beat it will be up, then next beat it will go down,
inside
like swimming in the water. So when it come up, you get a large complex. When it go down, you get a small
complex.
But these are not very common. But if you are taking an ECG in a large pericardial effusion, you will get all these things. Okay. Tamponade, it is not possible to take ECG or X-ray, all these things. Only echo can be done. Pericardial effusion can be diagnosed. If hypotension, bradycardia, try to tap it.
So pericardial effusion is mainly pericardial.
We worry about the ventricular puncture.
Ventricular puncture as such is not an issue, but the only thing is it can cause arrhythmia sometimes.
He's going to die. He's dying. If you don't tap, he'll die.
This condition,
This is an emergency, medical emergency. Immediately you have to act like pneumothorax, tension pneumothorax. If you don't do, patient will die. So better to do it and finish it, because immediately patient improves. If you tap the fluid, immediately you can see the heart rate increases.
So pericardial effusion basically is a collection of fluid in the heart. So patient can, if it was not an arrest, the patient could have come with breathing difficulty, chest pain, and maybe on examination we could have find distended neck veins because of this compression of neck vein structures. And the triad will be, as we discussed, distension of neck veins with low blood pressure and muffled heart sounds. And it could be secondary to like a traumatic condition.
What are the conditions you get pericardial effusion and tamponade in emergency room common?
One is chest trauma.
Chest trauma. Most important is chest trauma.
Then could be like a ruptured aorta or some other conditions like that. Then ruptured ventricle after a
Like malignancy.
Commonest
is trauma, malignancy, tuberculosis. These are the common things what we see in our practice. Okay. Tuberculosis is very, very common. We are not getting here. But if you take across India, it will be one of the commonest cause for tamponade. But it will be pus. It will be difficult to tap with your routine needle. But you can relieve the symptoms. Once you puncture it, whatever pus is there, it will come out. Either through the needle or it may just come out from the side.
Plus we can shift for this. And also, rarely we can get a ruptured ventricle after a recent MI. Could also be a cause. And also, if it was a patient was somewhat a stable patient, we could try treating him by treating the underlying infection like tuberculosis could be treated. And also, starting on anti-inflammatory drugs. And also, if the patient is secondary to malignancy, we have to start with radiation chemotherapy. It could also help in malignancy. And also, the patient is in acute heart failure, we can go for other heart failure drugs like diuretics and other drugs which can help improve his symptoms.
So, if the patient is having pericardial effusion, will you try diuretics?
No.
It is not correct. So when the patient is having a massive pericardial effusion, unless until you tap that, if you give diuretics, definitely this patient will go to cardiac failure because you are removing fluid. So there you have to remove first the fluid in the pericardial sac, then you try to give your drug.
Let's say early developing.
Early phase you can give, but in middle phase, not in the tamponade phase, not in the
like unstable situation.
That phase you should never try because that patient will go to cardiac tamponade if you give like that.
So the options for pericardial effusion is actually one, in emergency situation we can go for tapping the substitute process, approach. Second will be shifting to cath lab. Under fluoroscopy we can do tapping. And the third will be like a CT carrier tapping can also be used. And if none of this is able to relieve the symptoms, we have to go for surgery, like a thoracotomy has to be done, and then we have to manually drain the fluid effusion whatever is present. So that will be pericardial tamponade.
This one initial when you are approaching in the ABC pattern, you are seeing the airway is compromised. So next one is breathing. So breathing you could have noticed, suppose you are examining the neck itself, the neck vein enlargement, and if tracheal deviation is absent, the tension pneumothorax part may be They were excluded. But one thing we have to examine the chest auscultation. We did not enlighten any auscultatory finding when the patient is coming with a heartbeat intact. Only hypotension you told. So suppose you are auscultating that, definitely you could have pinpoint if there is a tension pneumothorax, absent breaths also. So other cause immediately you might have thought of cardiac tamponade. This is another thing. So you are auscultating heart sounds, definitely you could have pinpoint this one. So if you are going systematic, definitely you will not miss anything. And one more thing, you are thinking of an endotracheal intubation and positive pressure ventilation. Suppose it is because of the cardiac tamponade, this will worsen
the condition.
Okay. So when we have to adjust the pressure and try to manage the situation. So systematic protocol wise, if you are examining one by one, because the cardiac arrest is a next event one, and sometimes even CPR might have even caused him. Okay.
So can you rule out pneumothorax with your ultrasound machine?
Yes, we can do that. We can go for the lung sliding sign.
You have to look all these things because we don't know whether it is a cardiac tamponade, pneumothorax, like sir told. Initially itself, we should have seen all these things. You might have seen it, but you didn't tell it. And,
We checked in that way.
We are having facilities.
Then that ultrasound machine should be used. That also should be done. What is Dressler syndrome?
This thing, secondary to.
Okay. So MI or post cardiac surgery, all these things, it's immune mediated pericardial effusion. They have large pericardial effusion, but not tamponade. Tamponade is not common.
So pericardial effusion patients, if we are intubating and putting on ventilator, we have to reduce the pressures because every increase in pressure can actually reduce the cardiac output.
Correct.
So we have to maintain a balance between adequate tidal volume and also to get adequate cardiac output. So we can reduce. Pressure support should be considerably reduced as compared to a normal person to maintain a balance between the respiratory and the cardiac component. So this patient currently he is actually on his recovery phase, but is still on ventilator and on supports. But hemodynamically he is maintaining.
See, when there is a pus or pericardium, better we go for a drain. So the needle or catheter will not be getting blocked frequently. That you have to get to connect the drainage tube. And how do you know that you are tapping? Prognostic value. So when you are tapping sufficient amount is withdrawn, the BP will be
suddenly improve.
Increasing. What is pericardial decompression syndrome?
Rarely, actually, there has been some cases reported that sudden decompression can again cause worsening of the symptoms.
So usually they say 100 to 200 ml of fluid alone is sufficient. Suppose you want to increase more, not to exceed at least 500 ml. So when we are taking more and more, suddenly the patient will go for this problem. Okay, the person will improve the BP, everything. Suddenly
will again worsen.
Okay. Thank you.
Thanks.